Regular follow-up is vital for all childhood cancer survivors due to their lifelong risk of developing late effects. Due to the toxic effect of cancer treatment on children's developing organs, on average, each survivor will develop 17 chronic health conditions by age 50, with 5 graded as severe to life-threatening. Common late effects include second cancers, cardiovascular disease, neurocognitive impairment, and infertility. Given this serious risk, remaining engaged in lifelong care is essential to mitigate poor outcomes through prevention and early intervention. However, currently, childhood cancer survivorship care is delivered at just 8 clinics in Australia. As the most geographically dispersed country in the developed world, this presents unacceptably limited access, and as a result, over half our survivors disengage from care. Financially, these clinics are under-resourced to service Australia's growing population of more than 20,000 childhood cancer survivors. Only 3 clinics receive recurrent oncologist funding, with all others relying on oncologists volunteering their time, which places them at risk of closure, which would eliminate all access to survivorship care in multiple states. Development of a high-quality e-health model of childhood cancer survivorship care to provide access irrespective of geographic location is clearly urgent. As 5-year survival rates surpass 80%, and we now celebrate the fact that cure is the most probable outcome, we must ensure that we create accessible and equitable pathways for the long-term care of all our childhood cancer survivors. With this in mind, our aim has been to develop a patient-centred, distance-delivered intervention supported by innovative e-technology to provide quality cancer care to survivors at home. We named it ReEngage. ReEngage is a world-first online intervention to engage, educate, and empower childhood cancer survivors. ReEngage's design is that a clinical nurse consultant uses our purpose-built e-tool to collate each survivor's complex medical history and assess risk factors. This information is then presented at a multidisciplinary team meeting, which assesses survivors' levels of risk, healthcare needs, appropriate referral and treatment pathways. Survivors and their GP receive a written summary of the expert MDT's recommendations to support ongoing healthcare management at the local level. Then there is a second nurse consultant consultation, relaying this information, and importantly, answering survivors' questions. The nurse consultation also addresses survivors' barriers to managing their own care, and also provides lifestyle counselling so that the prevention, not the treatment of late effects, is the goal. We will use quantitative methods to assess ReEngage's effect on survivors' health-related self-efficacy, that sense of personal ability to implement healthcare advice, that's our primary outcome, as well as survivors' unmet medical and information needs and satisfaction with survivorship care. We will also assess the implementation of ReEngage, measuring healthcare providers' perceptions of ReEngage, its acceptability, barriers to adoption, clinical appropriateness, feasibility and sustainability, as well as the cost of the intervention delivery and participation compared to standard care. While we have only just recently started recruitment for our randomised control trial, I'm very pleased to be able to present the results of our pilot study here today. 27 survivors participated with an average age of 32 years. There was a 75% uptake of the intervention by disengaged survivors, typically one of the hardest groups to recruit. This strong response, along with the qualitative evidence, indicates that there is a strong need for distance-delivered interventions and that this intervention readily meets that need with very little burden on the survivor. We found that more than half, 54% of disengaged survivors, not currently receiving care were at high risk of developing late effects and second malignancies, and on average presented with 10 comorbidities, 10 chronic health conditions already developed. The graph on your left illustrates the most common recommendations the MDT made, with over 50% of disengaged survivors needing referral for psychosocial, endocrinology, ears or eyes, cardiology, and diet or exercise support. 100% of participants endorsed ReEngage as beneficial. 6 months post-intervention, significant improvement was demonstrated in survivors' self-efficacy to engage in their own healthcare, such as being able to discuss concerns with their doctor, being able to access the right follow-up care, being able to make appointments and decide when care is needed. As our primary outcome, this result was very encouraging. The ReEngage intervention is significant because it provides equitable care for all childhood cancer survivors by removing known barriers such as cost and distance. Its use of e-technology means that potentially half of the childhood cancer survivorship cohort now has the opportunity to re-engage and receive appropriate care in the survivorship period. The use of e-technology ensures ReEngage has remained patient-centred despite being distance delivered. It's a live intervention which supports patient-provider rapport and facilitates survivors' questions being addressed in real time via online Skype or telephone consultations with the nurse. ReEngage's nurse-led design is also unique. ReEngage's purpose-built e-tool supports sufficient standardisation for a nurse to implement a large portion of the care pathway. Nurse-led care lowers implementation costs and increases the feasibility of translation to practice by minimising the burden on oncologists' time. Innovative models of care, such as ReEngage, which utilise state-of-the-art e-technology, offer a feasible solution to some of the challenges survivors face. And we believe ReEngage has the potential to ensure survivors of childhood cancer can access quality, lifelong care. Thank you.
Thank you, Jordana. That was wonderful. Do we have any questions on one right at the front?
Heather from Griffith again. Just where are these 8 clinics?
Metropolitan capital cities.
All right, I have one. What are the challenges you see to implementing this solution now that you've done the pilot?
Yeah.
Do you see, what are the main challenges, do you think?
The MDT is a bit of a challenge. It's expensive and we have to coordinate everyone's time. MDT does have a GP in it and a psychologist, as well as a paediatric and adult oncologist and social worker. So that's fantastic, but that is a large resource. And then engaging the survivors, finding them and bringing them back in.
Sounds challenging. All right, can we have another round of applause for Jordana, please?